Hey everybody, it's Dr. Eric Balcavage, and I'm joined by my co-host, Dr. Erica Riggleman, and we're back with another edition of Thyroid Answers podcast. And today we have Donna Mazzola. She is a pharmacist, and you may say, man, you guys are talking to a pharmacist about thyroid stuff. I'm frustrated maybe with some of the medications I'm doing, but I think you'll really enjoy this podcast. We're going to talk about thyroid medications, the pros, the cons of different things, the differences between some of them, and we'll get into a really good discussion. Donna's not just a pharmacist, but she's really into the functional medicine and nutrition side of things. So Donna, welcome to the podcast. How are you today?
Great. How are you?
Doing great.
Thanks for having me.
Yeah. So can you give us a little bit of your background, how you went from more like a traditional pharmacist into this space of functional medicine and talking about things? And I mean, you have a blog called Doctorate, right? So there must be a story here. So can you share your story, how you got into the space with our listeners?
Yeah, absolutely. So I went through obviously conventional medicine training as a pharmacist, and even through that training, everything I learned never really sat well with me. It always felt like we didn't go deep enough into the why, and everything seemed like a Band-Aid approach. So somebody comes with a symptom, this is what we give them. So I always had this interest in nutrition. And I actually went back to school probably 3-4 years after I completed my doctorate of pharmacy to get a master's in nutrition. And I paused doing that. I had started having kids and whatnot. And so I always told myself I would go back into it. And it wasn't until 2015 when I personally was diagnosed with Hashimotos thyroiditis that I was blown away, because I thought I was healthy. And the first thing that came to my mind is how can someone like me get an autoimmune disease? I don't understand. I mean, I eat well, I exercise. And so I started to dig deeper into really, the etiology behind autoimmune disease, how it comes about, and what factors contribute. And I had no idea, even having gone through, 6 years of conventional medicine training as a pharmacist, that so many environmental factors and nutritional factors play a role in the development of autoimmune disease. And so that's when I said, okay, I always wanted to do this, so now I'm going to go back, and I'm actually pursuing currently a Master's of Science in Functional Medicine and Human Nutrition to kind of balance out my current conventional medicine degree. And so with that, I do have a blog, Doctorate, and I started that because I felt like I'm essentially started this degree just to educate myself. I mean, some people will think I'm crazy because, like, oh, you're getting a master's degree just so that you can educate yourself to help fix yourself. And I thought, yes, because what I'm finding on the internet, I mean, everybody and anybody is putting out information, and I couldn't find any. I didn't know what was reputable and what was not. I found myself having to do so much of my own research that I thought, well, as I go through this program, I'm going to create my own blog and provide everybody with what I'm learning. Because I know it's reputable, and I can back it by, whether it be clinical studies that have been done, or at least the references and resources where it comes from, so that people have access to reputable information, because that's where I struggled with controlling my disease. And so I'm hoping right now my blog is essentially there to empower people to learn how to take control of their health, and, to unmask the unknown of autoimmune disease.
Great. Yeah, and we talk about on the podcast all the time, and one of the reasons we started the podcast is because everybody was really focused on the gland. And from our perspective, it really is about what's happening in cells in the tissue, because that's what really drives hypothyroid symptoms. I mean, you could have glandular hypothyroidism, not produce enough gland or enough hormone, be put on thyroid medication, and yet lots of people still struggle with chronic hypothyroid symptoms, and they're saying, doctors say, hey, your TSH is normal, T4, T3 in the bloodstream is normal, you're good. But the reality is you're only good if you get sufficient T3 to the receptors, nuclear receptors in the cell, and that stimulates appropriate metabolism. If you don't get appropriate T3 to those receptors, then you're going to have hypothyroid symptoms regardless of what's happening in the bloodstream or the gland. And so the other thing that's really important there is sometimes we look at hypothyroid symptoms or hypothyroidism in general like it's a problem, like it is the problem. And our take on that is a little bit different, where we say that the reality is thyroid physiology is an adaptable thing to some type of stress or strain or danger on the system. And when the cells perceive stress, danger, then you have a downregulation of thyroid physiology in the cell or tissue. And that is a normal adaptation to that stress or danger. And maybe we shouldn't be flooding a system trying to force the physiology, which we often do in both functional and traditional medicine, to make us feel good, make the labs look normal, when in reality, the body's doing exactly what it's supposed to do. And especially when it comes to thyroid physiology, when you have that cellular hypothyroid state, that lack of T3 at some receptors slows metabolism, but the lack of T3 at some of those nuclear receptors also triggers some of that defense mechanism, some of that danger response that's appropriate, because T3 both activates things and also by binding, and when it binds to other receptors, it shuts things off. So we look at everything really more from a cell perspective first, then we consider that autoimmune process in many cases to be an extension of that cell danger response. And eventually we see the hypothyroid physiology at the gland, but we don't always look at that as the mistake, but really the body trying to slow metabolism to protect itself against some unknown danger. So when we talk about thyroid medication, because this is your wheelhouse, there's a few different types of thyroid medications, and probably the one that most people are familiar with is synthroid, right? And then there's a generic model medication called levothyroxine. Can you talk a little bit about those two as the primary? We'll talk about maybe tyrosint and some of the other things as well, but talk about synthroid, what it is, and levothyroxine, what it is, and what the differences are.
Sure. So synthroid and levothyroxine really are T4 hormone. So that's when we're talking about thyroid hormone replacement therapy. I think it's important to also understand the physiology behind the thyroid gland. And so, you have T4 and you have T3 hormone. And so T4 hormone is essentially a prohormone that needs to be activated into the active form of T3. So when we're looking at medications and talking about synthroid and levothyroxine, those are T4 hormone only. They're a synthetic hormone that is essentially, given and should mimic what your body's normal response should be, to converting T4 to T3 hormone. Obviously, the difference between the two is one is a branded product and one is a generic product. Synthroid is branded, and synthroid and levothyroxine have become really the mainstay of hormone in the conventional medicine model, the mainstay of treatment for patients with hypothyroidism or Hashimotos. And so we see many patients that are on synthroid and essentially are actually, based on coverage decisions, things like that, are taking actually the generic product as well. And a lot of times people still complain about symptomology despite their numbers looking really good on paper. And so really when we're looking at differences between branded and generic products, I mean, essentially there's active ingredients and there's inactive ingredients when we're looking at medications. And the expectation is that the active ingredient between the two is identical. Unfortunately, there aren't regulations across generic products are pretty loose, and they're not as stringent as they would be with branded products. So when a branded product comes to market, obviously it goes through, phase 1, 2, 3 clinical trials, goes through FDA processing, review of data. Once that patent is up, pretty much any generic manufacturer can make that product. And there is not a requirement to submit to the FDA to review the quality of that product, what's in it, and determine efficacy, determine safety. It's just kind of an open door to, you can pretty much, retrieve the active ingredient in powder form and create whatever formulation you want as a result of that. So that's the challenge with generic medications. And like I said, the other part of it is the inactive component. And so as we know with many autoimmune conditions, especially with Hashimoto's, is that many people respond, have a poor response, I should say, to, a lot of these inactive fillers that are put in to these various formulations. And a lot of times they include things like lactose, gluten, soy, things that are gonna kind of create that imbalance, where I always try to focus on the balance between nutrition and medicine. And that's just going to shift that balance. And so even if somebody was on, let's say, synthroid and was, seeing a response and feeling better, and then they were switched to a generic product, and you're questioning, why did that happen? They're supposed to be the same. It could very well be, alterations in the dosage. May not be exact, because there is a window that is allowed, um, that allows kind of for that, like an error right between that. So it's not always 100% conversion from a branded to a generic product. And when we're looking at medications for, like thyroid replacement, they have a very narrow therapeutic index. And basically what that means is the smallest change, can result in a, vast difference. And so it really does need to be identical. That's why we push, taking it at the same time, and, avoiding certain things with it, because the littlest alteration can cause a huge change. And so, kind of the combination of all of that, I think a lot of times is why patients, don't respond the same and can respond differently depending on the formulation.
Yeah, I think that across the board, I think me and Erica both have seen that with our patients coming in, is that, they say they may have had symptoms when put on a medication and got switched, and then, things flared up or they started to regress. And, people even come to us already working on the gluten, the dairy. And I think that talking about what's in our medications is a really important thing as well, because in most cases, patients do need the medication. That's not something that can be compromised, but if there can be a better choice that doesn't have the fillers, doesn't have the binders, I think is really important to talk about, because honestly, their doctors aren't going to talk to them about that. They may tell their doctor that they're gluten-free or dairy-free, but their doctor probably doesn't even know that the generic form doesn't have that stuff in it. And it may not even come down to what the doctor is recommending. It may be an insurance thing, of why they have to be on the generic.
Yeah, absolutely. That's usually what it comes down to.
I heard it said in a recent interview, but somebody's coming out a book on the industry, and what they were saying is, and you can correct me if I got this wrong, but essentially when the product comes off label, right, it's now available to be generic. There's a line at the door, and whoever applies first gets access. And what they get kind of the basic formula of what's in it, but they don't give them necessarily the dosage of everything. And so it's like me telling you the 5 ingredients that's in my secret granola recipe, but I don't tell you how much of each ingredient. And so what happens at the company that's making the generic product is they're trying to figure out or formulate that same mixture, but they don't have the full ingredient data that they need to really make the identical product. Have you heard that? Or are you familiar with that?
Yeah, so I mean, essentially what you need is to basically derive the exact amount of the active ingredient. But exactly right, is you don't know what else was in there.
Right.
You know that there's 25 micrograms of levothyroxine in this tablet, but everything else is an unknown. And really, you can formulate it however you want, as long as you have that 25 micrograms of levothyroxine in the tablet. And so these, obviously considering the disease state and the active ingredient itself can react differently within the body depending on what some of those fillers and binders are. And so that's the complexity. And so I think sometimes, and I think it's especially, and like I mentioned, because there's this narrow therapeutic index with these products, is that it's especially important when we're looking at, thyroid hormone replacement therapy, because like I said, the littlest change can cause a really big difference for patients.
Great. So somebody's talk, I kind of already introduced this topic a little bit, but somebody starts taking synthroid, their TSH normalizes, T4 normalizes, doctor's happy, patient maybe not so much happy, right? So from your experience, why would you say that patients might continue to experience symptoms despite having normalized TSH, T4 and being on synthroid?
So a lot of times in those situations, studies have shown that about 15% of patients that actually take synthroid, continue to have symptoms. even though their TSH has normalized. And a lot of that, what is attributed to, is the lack of ability to convert from the T4 prohormone to the active T3. And really, like you had mentioned, that's our go hormone. That's what we need, to be able to get into the cells, to be able to actually produce the effect that we need from, a metabolism perspective. And so they will continue to have those symptoms because, they may have an abundance of, T4 hormone because they continue to replace it, but they're not able to activate it. And that can be attributed to, multiple factors within the person themselves. It can be attributed to nutritional factors. Stress in and of itself can impact that. And so it's important, and the challenge, I think, with many patients, especially in conventional medicine too, is that a lot of times doctors will just look at the numbers and sometimes forget to listen to the patient, that despite the numbers looking good, we kind of have to take it a step further and think about what else can we add to this patient's regimen, and what other nutritional components or environmental factors can we be looking at that could be contributing, why this patient is not actually getting the effect that we're expecting to see, or that what we're seeing on paper is not actually materializing within the patient.
Yeah, and so one of those things I think we should kind of add to that process too is typically, like when we're talking about what's regulating TSH and T4, we're really talking about what's happening at the brain, at the hypothalamus. And the hypothalamus and the pituitary gland are much more sensitive to T4 and T3 than a lot of the peripheral tissues. I think that it's like a 20 to 1, 20 times more sensitive. So it takes really small, minute amounts of T4 and T3 to really support the hypothalamus, lower TRH and TSH. But if the peripheral tissues are 20 times less sensitive, we're going to normalize TSH much faster at the brain, hypothalamus, pituitary than we are in the rest of the peripheral tissues. And the other piece for the listeners to remember is not all tissues regulate thyroid physiology the same. It's really based on the needs of individual tissues. So just because your TSH is normalized and you have plenty of T4 in the bloodstream doesn't mean that you're getting the appropriate conversion inside the cells and tissues, right?
Absolutely.
So we've all seen, that scenario where we're not converting, or the patient has tried, when they first go, we often see people get put on synthroid, levothyroxine. And I think the next cascade is they go back to the doctor saying, I'm not any different. I still have these symptoms. And they're often pushing the doctor to prescribe a different type of medication because they think it's this formulation. So they think it's the synthroid or levothyroxine. So they often push for the next medication. So could you explain some of the other medications that are on the market that some people may, push their doctors to prescribe because they maybe read it on a blog that somebody else maybe switched to a T3 only because maybe it was a T4 conversion problem? Can you talk about some of those medications and maybe what some of the pros and cons of those are?
Yeah, absolutely. So yes, like you said, T3 hormone is obviously another one. So we focus so much, and like I said, that is the mainstay of therapy when providers are looking at guidelines on how to treat, hypothyroidism. That is the go-to product, is a synthetic T4. But there is T3 available on the market. Cytomel is the branded product there. And the problem, I would say, with the T3 agents is that they work very quickly and they leave the body very quickly. So they have a very short half-life. And so they can kind of put patients on a roller coaster. But for those patients that maybe do have that conversion problem, I have seen a lot of conventional medicine providers that will try to balance between the two, which, is also challenging. But between drawing their T4, their T3, and their TSH levels, trying to figure out the right balance and the right amount of medication to get those patients controlled or feeling better. So they essentially start to supplement with that T3 and still providing that T4. And so again, that's complicated because are we addressing the issue with the conversion from T4 to T3, or are we just throwing more hormone at the patient? And then the question is, do we need as much T4 if they're not converting it? Where is the benefit of that? So yeah, it makes this whole process super complex, right? The other products that are on the market are the glandular products. So your desiccated thyroid hormone. which is, natural desiccated thyroid hormone that's it's derived from pig thyroid glands, and it is bioidentical to human thyroid hormone. And so those are another option. A, most conventional medicine doctors, I will say, steer away from those products. They've kind of gotten a bad reputation in the past because there were issues with manufacturing of these products and inconsistencies between lots. And I think it's important, number one, to understand that manufacturing processes have improved, and we haven't seen those consistencies recently between those products. And so that's your Armor, your NatureThyroid, your WP Thyroid, that provide both the T4, T3 component within one tablet. But like I said, it's a balance, and that's kind of the message that I always push, is that it's a balance between the two. We can't just, with any disease state, not even just talking thyroid, but we can't just throw the medication and completely ignore, kind of the other side of it that's contributing to the disease state in and of itself.
So one of those that we didn't talk about was tyrosint. So can you explain the difference between tyrosint and synthroid, levothyroxine? What's the difference?
Yeah, so tyrosint, obviously we talked a little bit about active and inactive ingredients. And so tyrosint, I guess I would refer to it as a clean version of T4 hormone. So it doesn't have a lot of the inactive ingredients that we would see, that we see in synthroid. And honestly, if you look up, inactive ingredients of synthroid and tyrosint, tyrosint, I think, has 3 inactive ingredients in it versus the longer list that you see within synthroid. And so a lot of and a lot of those inactive ingredients in synthroid, include lactose, gluten. And so patients have reported, improvement in symptomology just from switching, and it's probably likely due to the impact that these inactive ingredients are having on the overall disease management.
So if we kind of summarize it, the levothyroxine, synthroid, and tyrosint, all T4-based supports. The difference being that synthroid's the branded, that was the original version. Tyrosint's really a cleaner version of it, less active ingredients in it, or non-active ingredients in it, things that could trigger more of an immune or allergic response. And the levothyroxine is a formulated version of synthroid, still has a lot of inactive ingredients, and it may or may not have as beneficial effect because of some of those other inactive ingredients that are added, right?
Yeah, absolutely. And the other thing is that tyrosint and synthroid are manufactured by a single company, where the levothyroxine generic can be manufactured by any generic company. And so that's the challenge with, kind of that regulation of it, and what are those inactive ingredients.
Right. Now, I do want to get back on the T3, because one of the big pushes especially in functional medicine, is people say my reverse T3 is elevated, so my doctor is going to put me on T3 to lower my reverse T3. And for me, I have a couple problems with that, and so maybe I can get your opinion on that. First of all, T4 is converted to reverse T3 by the cells, by enzymes that are what we call deactivating enzymes. So T4 can be converted to reverse T3. Everybody, we talk about it like a less active or a deactivated form of T4. There is some active function of reverse T3, so I don't want people, if somebody says, well, it has a function, it does, but in general, we'll say it's a less active form. Many people in functional medicine space say, hey, if you have elevated reverse T4, we'll give you T3, it'll lower your reverse T3, because reverse T3 blocks the nuclear receptor. Now, I've read, I don't know, hundreds, if not thousands of research papers. I've never once seen, and I've also studied where the deaminases are made and released, but I have yet to see a validated paper that shows that reverse T3 blocks the nuclear receptor. Have you seen that anywhere? It's talked about, but I haven't seen it anywhere.
Yeah, I agree. No, I haven't seen anything to kind of substantiate that that physiology.
Yes.
Like you said, it's talked about, and
So for the listeners, where reverse T3 really takes its action at is either at the plasma membrane of the cell on the outer edge of the cell, or that reverse T3 is released through little vesicles called exosomes into the space outside the cell, and the deactivation seems to occur there. Where I think the confusion occurs is that reverse T3 can actually block receptors on the outside of the cells called integrin receptors. And that's a good thing because we don't want excessive amounts of T4 binding to those integrin receptors if we have sick cells, because T4 binding to those receptors can cause those sick cells to multiply. We don't want that. But the idea for people that when they say, hey, I'm going to take T3, it'll lower your reverse T3, that's an easy one, because if you don't have T4, you can't make reverse T3. But isn't it also true that those deiodinase enzymes that were deactivating T4 also work on T3 and can deactivate the T3 as well?
yeah, absolutely. So you have, you have 3 different deiodinase enzymes, right? And so I think that's important to understand that, you know, and unfortunately, I think this is a challenge is, it'd be nice if we could assess a person's deiodinase enzymes, right? I think that would create a whole, much more holistic picture of what's going on, as opposed to simply just looking at, reverse T3 and, you know, that conversion between the T4, T3, or to reverse T3.
And we don't have the ability currently in a clinical setting to measure deiodases or T2. And T2, there's 4 T2s, right? And there is some activity of some of those T2 variants. But I think where people, especially in a functional medicine space, they're thrilled because somebody's reverse T3 is down, but they're not aware, but the person could still be symptomatic because they're not getting the T3 to the receptor, because it may be still being deactivated by the same processes that were deactivating the T4. And there's some complications. By taking T3, what are some of the symptoms that somebody might experience by taking T3? And what are some of the challenges with taking T3 supplement only?
Yeah, so like I mentioned, it can put people on this roller coaster, right? So it can, obviously it's the active form. So, you can drop that, drop TSH and increase T3 really quickly. Patients will likely, it's hard to monitor and control. So if they're on only T3, they're likely going to be experiencing, and if they're, obviously their T3 is too high, heart palpitations and cardiovascular symptoms is what we're most concerned with. And so, when I go back and I talk about kind of the history of thyroid disease treatment, in the beginning, that's what we use T4, T3 combination. And I think that unfortunately practitioners were seeing that, patients on higher doses of T3 were getting, seeing a lot of weight loss. So it started being pushed kind of in, as a weight loss agent. And we started seeing much more complications with cardiovascular disease. And so that's kind of where, when synthetic T4 came out, it was like, okay, this is the safer alternative. We don't want to be using T3 whatsoever. And so that's kind of what's skewed, treatment within the thyroid space for so long, and why conventional medicine practitioners just completely stay away from T3 hormone is kind of because of those side effects that we're seeing early on, and kind of where guidelines then utilize that information to say, well, this is how it needs to be treated, and we really need to just be focusing on TSH, and monitoring that value.
Yeah, and so one of the other things that's really important for the listeners to understand is there are some tissues that can't convert T4 to T3. They can only use T3 that comes from the bloodstream, and some of the cardiac tissue are some of those tissues that require T3, and so they can be supported really easily. And you can take T3, you can have, we see anxiousness, anxiety, some of those really hyperthyroid symptoms that occur, especially neurologically. We can see people ramp up real easily, but still have some peripheral tissue issues and symptoms, because those tissues still have the ability to deactivate that T3. And a lot of the peripheral tissues, based on my study and research, really prefer to control and self-regulate thyroid hormone physiology via those deiodinase enzymes so that they can control how much of that T4 is converted to T3, how much of that T3 and T4 is deactivated. So it's, I wish, and I'm sure, Donna, you would say the same thing, it would be great if there was a one pill that fixed it all, but at the end of the day, the medication is there to support kind of the foundational need that we have to kind of fill the void, but at the end of the day, we still need to address what's causing the cellular deactivation, what's the stressor, what's the trigger, and what's driving immunity and autoimmunity.
Yeah, absolutely. I mean, it's such a complex issue. You know, I think that we, unfortunately, it's not always looked at that way. I can say personally, when I was diagnosed, people were like, "Oh, big deal. It's just you just take a pill for that. It's not a big deal." And I'm like, you know, I was like, "What? What do you mean that's not a big deal? Of course it's a big deal." And it's like that lack of understanding of how complex and how important that gland is, you know, to the overall functioning of the body.
Yeah, I think there's a lot of people out there who just think, oh, it's not a big deal. You're just gonna have to take a pill for the rest of your life. Or even patients come in who have already had their thyroid removed, whether it was, you know, back in the day when they would just eradicate it because of Hashimoto's, or if there was some sort of cancer, people are just look at it and say, well, that's not a big deal. You can just take a pill to fix it. And it is so much more complex than that, because there's probably a lot of listeners sitting there right now saying, okay, you've talked about this pill and this pill and this pill, but which one's the best? You know, which pill's the best for me? And I think that that comes back to customized medicine and what we focus on in functional medicine, that there's not one thing that works for everybody, and that, you know, working with your doctor to figure out what's the best, but then working on the actual physiology and asking the questions of, well, why are you having these thyroid symptoms in the first place? I think is going to be really important for the listeners to understand that there's always a mechanism, whether it is diet, lifestyle, there's something that is causing the thyroid pathway to become dysfunctional. And a pills, in most cases, isn't just going to fix that on its own. You really want to work on the physiology.
Yeah, I would absolutely agree.
So can we talk a little bit about when somebody's taking these medications, there's a lot of discussion about things that can disrupt the absorption, when they should take them, how close to food, how far away from food. So if we talk about synthroid, levothyroxine, tyrosint, Cytomel, what's the best way to take them? How far away from food? Can they take them with any of their supplements, with no supplements? Can you get into that a little bit?
Yeah, so really, these medications all need to be taken on an empty stomach. The one, and you asked, like, can they take them with any other supplements? And I'll get into that. But I mean, essentially what we can, you know, tell patients and counsel on is, you know, avoid taking them with any of your supplements, vitamins, calcium, any antacids that may contain aluminum, things that can bind the actual hormone, and therefore you're going to get a reduction in absorption. So, you know, kind of, I think for ease, people just say, don't take it with anything. I think one thing that I've found in practice is that, you know, patients consider coffee to be water. And so when you say take it on an empty stomach, you know, but you can take, you know, take it with your water, people would take their thyroid replacement hormone, you know, with coffee. And so I actually came across a study that actually looked at that. I actually studied it myself personally, because I found, you know, I was waiting 30 minutes and then drinking a cup of coffee in the morning. And I saw, you know, at the next time I had my labs drawn, an increase in my on TSH and reductions in my, you know, T4, T3. And so separating it out by 60 minutes actually, you know, brought things back into optimal range. And there was actually a study that was published in the Thyroid journal that found that there was about a 25 to 75% reduction in T4 hormone absorption when people were taking their medications with coffee. And so I think it's like, don't take it with other medications is kind of an obvious, but then it's like the not so obvious that's more important to talk about patients. And there's simple things that they do in their everyday life. Like, yeah, I just wake up and then I have my cup of coffee, but I'm still on an empty stomach because that's what's assumed as an empty stomach. But like I said, it's that narrow therapeutic window that is so important, because the littlest things can impact that absorption.
So would you say 60 minutes is a good time frame, or should it be longer? before they take any of their supplements, coffee, anything other than water?
60 minutes, I mean, if they've been on an empty stomach and they take it, then 60 minutes is a good time frame. And that's what studies have found to be sufficient as well. If they've already eaten or have taken other supplements, and then they want to take their medication, we need to wait about another 4 hours before that. So if you've been
Wow.
on an empty stomach, so you're waking up in the morning, you've fasted now probably at least, maybe 7, 8, 9 hours. So you've been on an empty stomach. If you've already eaten, you got to wait even longer. So it's best to take it in the morning.
In the morning on an empty stomach, and 60 minutes to wait before you take any supplements, any food, and 4 hours if you've eaten. You should wait at least 4 hours. So for those people who get up in the middle of the night when they're nibbling and having a little something to eat, and you go to bed at like 3 o'clock in the morning, and then you get back up at 6 a.m., and then you take your thyroid medication, you're probably not getting the absorption of those things as well as you should, right? What about things like alcohol, right? So we have patients, people are real, they have a little bit of alcohol. If they go out and have alcohol in the evening and they get up in the morning and they want to take their thyroid medication in the morning when they get up, how does that impact? And as long as they're past that 4-hour window, are they okay?
Typically, I would say yes. I mean, the other thing that we have to remember is that we can't be, it's kind of a balance. So, if you try to make it too unrealistic, patients, number one, aren't able to follow it. And I mean, realistically, even if you did take something, when you took it, you're going to get some absorption, maybe not 100%, but then maybe next day they do, or the next week they take it as prescribed. I mean, that's why we look at the ranges when we check labs over a 6-week period, because there is that variability in absorption. And, it's hard, but we can't expect people to take it exactly. We always hope that, right? That perfect scenario. With alcohol, I haven't seen anything specific to say. I mean, my recommendation would be that yes, if you had drank and you've passed that period and you've basically fasted and you haven't, throughout the night, and then you wake up to take your medication, it should be sufficient. But in terms of a time period for alcohol and thyroid, I haven't seen anything particular studied. I don't know if you've seen anything specific to that.
I haven't. How about, is there anything that really improves the absorption of these things that are supplemental? Is there anything that increases the absorption that you've seen?
Yeah, so the one supplement really is vitamin C that can be taken with thyroid medication that actually improves absorption. And the reason for that is that it actually increases gastric acid. And so that can help to increase the thyroid medications, what's been found. And so a vitamin C dose of about 500 milligrams daily has been shown to be sufficient to improve the absorption of thyroid medication. And really what I did come across a study recently that actually found that for patients that compared patients that took their thyroid medication with vitamin C and those that took it without, and they found a reduction in TSH with an average of about 69% in those that took it with vitamin C versus those that didn't. So, I mean, there is data out there to support that. And so if people, obviously, a lot of times we do find with our autoimmune patients that they do have issues with gut integrity and issues with pH balance. And so, that may be just another factor that we can add in from kind of that nutritional environmental side to try to help that absorption. Because at the end of the day, we want people to be on the least possible effective dose, right? We don't want to try to keep increasing the dose of medication. We want to try to identify what that root is. And if absorption is an issue due to issues with gut integrity, then vitamin C could help with that.
So we should kind of talk about that. You need appropriate cellular thyroid levels to actually make stomach acid. And so if you have hypothyroidism, the tendency for you to have lower stomach acid production is pretty high. And so taking vitamin C can help support that. Things like how about things like apple cider vinegar or as an agent to help stimulate stomach acid production, or digestive bitters? I don't think most people are going to take those on an empty stomach, but we're taking those things pre-meal. But one of those things to consider is if you have low stomach acid, if you have reflux symptoms, your acid production is probably low. And so I think, Donna, if you can argue or disagree with me if you want, but probably on a regular basis, making sure you're supporting regular stomach acid production is one of those things that you want to do. And the vitamin C would be one of those things that you take that's helping increase that during the time you're taking your thyroid medication. But the rest of the time, if you know that you have those things, doing things to support stomach acid production is going to help you in the long run. Would you agree with that?
No, I would absolutely agree with that. And I think that another thing that we have to consider is that so many patients, especially in Western medicine, are, look to proton pump inhibitors because of certain symptoms that they may have, and therefore they're reducing stomach acid because they're trying to alleviate symptoms that they may have with reflux. And so, a lot of times people will say, well, I don't take it with my thyroid medication, so it should be fine. But it's understanding, like you said, that overall physiology of what is actually needed for the absorption. And if you're inhibiting stomach acid, then, there's a problem right there. And that's where people are going to, you see people on these really high doses, like people who are just diagnosed, who are started out on really high doses of synthroid. And you're just like, what is going on? Why is it that you're not, able to absorb this? And so it's kind of drilling down to what other medications are they on? But yeah, supporting kind of that natural method to increase stomach acid is essential.
Do you find that there's a link between people who have like autoimmunity, who may have like leaky gut, that often there's less absorption or decrease absorption of their thyroid meds because they have integrity issues of their digestive tract?
Yeah, absolutely. I mean, that obviously plays hand in hand with that, decreased acid production. Then you have other toxins that can impact the overall, picture of thyroid physiology as well. Obviously a lot of these like xenobiotics that we're being exposed to, pesticides, things like that, that are kind of killing off that gut integrity, are going to impact certainly the absorption of medication. So I always say you can't have one without the other. It's a balance. You have to look at both. And you have to look at the thyroid medications just as a support tool, but the other side of it, the environmental and the nutritional factors, are what is imperative, right, for the longevity of your thyroid gland and for overall physiology.
Are there any other medications that you can think of that you would say, hey, if you're taking this medication, it could impact the absorption of your thyroid hormone?
Other medications, or you mean like supplements?
Well, yeah, well, they're not, even if they're not taking those with the thyroid medication, is there any other medications that they may take, sometime during the day or even in the morning that could impair thyroid hormone or thyroid medication in absorption? So
yeah, I mean, things like iron as well can impact thyroid hormone absorption. Like I said, antacids are a big component too that people may be taking. But I mean, iron supplements, a lot of people are, take iron, especially in the functional medicine world. You see a lot of times not really understanding. I think I've seen some even functional medicine practitioners not really looking to the root of why somebody may have low iron, and certainly just kind of throwing iron supplements at them. So it's kind of getting to the root of why do they have low iron, and then that definitely interacts and decreases absorption of thyroid medications. So, and that leads back to gut integrity, so that's really why they're having low iron. So let's kind of drill down to the root of why.
Yeah. So how about when we talk about other medications, one of the things that I could think of that I would say for most people maybe have a little bit of caution of, if you're taking a lot of antihistamines, are going to decrease stomach acid production. If you decrease stomach acid production, you're going to have decreased absorption. So if you're a person who's taking a lot of antihistamines, you need histamine to drive stomach acid production. So if you're taking antihistamines on a regular basis, decreasing stomach acid, there's kind of a scenario. Hey, I've got allergies because they got unknown gut issues, right? And so then they take antihistamines. The antihistamines decrease stomach acid production. And so now they take a proton pump inhibitor to reduce the reflux. And now they're taking, they may develop hypothyroidism along with it. And now they're having decreased absorption of those things. So watch your antihistamines. There are some natural products that can support histamine production, but definitely if you're taking antihistamines, I would say that's one of those issues. Iron, definitely, yeah. And I agree with you. There's a lot of people in our space, in the functional medicine space, that really, I don't fully understand the difference between anemia, iron deficiency anemia, anemia of inflammation, or anemia of chronic infection or chronic disease. And I really think the anemia of chronic infection or chronic disease is the more prevalent form of anemia than iron deficiency. I mean, we only absorb about 1 milligram of iron through the GI tract and lose about 1 milligram every day. Most of the rest of it's recycled. And so for the vast majority of people, we are looking, they're looking at the iron marker and maybe the hemoglobin and saying, oh, you're iron deficient, and not looking at some of the other markers to see, especially things like ferritin, to see that, oh, my ferritin level's elevated, and that may really be an indication that the body's sequestering iron because of some type of chronic inflammation or infection. Do you want to speak to that at all? Do you see that?
Yeah, I mean, absolutely. I think that getting to the root of the inflammation is key. And so, I mean, I think you spoke very eloquently on kind of the process of iron and where kind of we're missing the picture, and people just focusing on, iron levels are low, let's just keep throwing it at them, and they're storing them, but we're not utilizing it, right? And so we're not utilizing it because there's a bigger inflammatory process that's going on within the body. And, it's even when we're talking about, and I'll kind of maybe take on a little tangent, but going back to the kind of thyroid physiology and people with Hashimotos and looking at antibodies within Hashimotos, a lot of conventional medicine endocrinologists will steer away from drawing antibodies because they say, well, you're always going to have them, so it doesn't really matter. Like, you have an autoimmune condition, I don't need to keep checking them. But really, it's kind of looking at it to focus as a measure of inflammation. So if you have antibodies, but we've started you on medications, and at the same time we've initiated several different methodologies to reduce inflammation from a nutritional standpoint, supplemental standpoint, whatever it may be, removing toxins, because of that, we're able to not only look at our TSH, our T4, T3, but now we're also able to see that, wow, I see a huge reduction, a 5-fold reduction in your antibodies. So it's kind of like a measure to both sides to see, like, the medications as well as, that anti-inflammatory picture is working. And so if iron is a result of an inflammatory process, then throwing iron at that is, not going to improve, right, the overall picture. And again, if we're kind of taking it a holistic approach, it's also not going to be helping kind of that inflammatory process where we're seeing these elevated antibodies.
Yeah, there's Dr. Douglas Kell has done a number of great papers on iron dysregulation and how part of the process of the natural immune inflammatory defense process is to sequester the iron, because really what happens in a lot of people who have chronic inflammatory disorders or autoimmune disorders is they have chronic latent infections that are activated by iron. And so by sequestering the iron out of the bloodstream and into storage form as ferritin or hemosiderin, now that the organisms can't utilize that as fuel, and it's a protective mechanism. And if we throw more iron into the system, are we really benefiting the person, or are we maybe potentially prolonging chronic infections by trying to fix it? Plus, the iron can become part of the reactive oxygen species and just create a host of issues. So there are people who are definitely anemic, iron anemic, without a doubt, but I think there's a much larger proportion of people who just have anemia of chronic inflammation or anemia of chronic disease. So we want to kind of wrap this up. With your background, we've got people that are struggling with thyroid issues. They're taking their medications. They're not happy. As the pharmacist, what are some of the general recommendations you would give to somebody regarding medication and addressing thyroid physiology if they've got diagnosed with glandular hypothyroidism, with Hashimotos, or they're what we call cellular or tissue hypothyroidism? They have normal TSH, T4, but they're struggling with all the symptoms of hypothyroidism.
Yeah, so I think that for most people, the starting point is going to be put on medication, because that's honestly, you're going to your physician because you're having symptoms of fatigue, your hair is brittle, you're gaining weight, whatever it may be, and you go to the physician, your practitioner, they draw labs, and we're seeing a picture of hypothyroidism. So essentially, most people are started out that way. They're put on medication. And I think that's okay, especially to start. But I think that more importantly, we talked about how to take your medication. Make sure you're taking it on an empty stomach, waiting 60 minutes before you eat anything to ensure you're getting the greatest absorption. Adding vitamin C to that, trying to do other measures, like you said, apple cider vinegar to increase overall stomach acid is going to improve absorption. So that's one aspect. So I think the challenge is to get on the right dose, okay? And we see that we have to, a lot of times patients have to fluctuate and change doses periodically as soon as they start. So doing all those things up front to ensure, to kind of get a measure of what is that dose doing for me. But then on the other side, dietary components. Things that I recommend personally are eliminating dairy, gluten, and soy. Those three factors can impact thyroid physiology. We probably can't get into all the details around that, but those are three inflammatory factors, inflammatory foods that I always recommend to eliminate. And that's kind of from the nutritional side of it. Eliminating those, and I don't like to throw too much at patients, but to try to start out with eliminating those three things in your diet, starting on the medication, taking it appropriately, and then, honestly, within 6 weeks, there's probably, hopefully, likely to be an improvement, and maybe an improvement to a point where maybe that dose can be even reduced. Because a lot of times, just depending on what that starting dose is, it can go up or down, but you don't want it, you never want it to be increased if it doesn't need to be, if there are things that are in your control that you can do to kind of keep it at the lowest effective dose possible.
Great.
Awesome. Those are good.
Erica, any final comments before we wrap this up?
I think this is a great information, because most of the thyroid listeners out there are probably on a medication and may not have even been instructed on how to take their medication or know the difference between them. So I think this is a good kind of background so they understand. I think patients need to be aware of all of their treatment options and know what it is, and empower themselves to know that the medications are okay to be on, but there's different types. But then we also want to work on the functional medicine stuff as well.
Absolutely. And I think that's a key thing. If you're in the medications can really support the crisis mode, right? If you're hypothyroid, TSH is sky high, T4, T3 are low, yeah, you got to get some hormone support into the system. You may not feel fantastic with it, but you still have to normalize. Thyroid hormones critical to some of those tissues. And you may have had so much destruction of the gland that you're just not producing significant levels. Recent paper not too long ago said that by the time TSH actually goes above the current lab range to be diagnosed as hypothyroid, the person's lost about 90% of the function of their thyroid gland. So TSH is not an early indicator of thyroid physiology problems, and you have quite a bit of destruction. So I know I've had many people that say, listen, I don't want to take it, but if you're really in a state where your gland just can't make it, one of the best things to do is to get some immediate support. So Donna, I totally agree with that, and same with what Dr. Erica said. But if we don't address the root cause issues or address that cellular physiology piece, why is the cell deactivating thyroid hormone, then you're going to be persistent in some of those tissues with chronic hypothyroid symptoms. So that's really the focus of the podcast. I think it's the focus of what Donna's trying to express is that, hey, we need to address root cause issues. We can provide a Band-Aid approach, which we do so often with so many conditions in medicine. And that's really the purpose and the focus of medicine is to be, crisis management. And over time, we've gotten away from looking at root cause issues and dealing with the root cause, whether it's just because the providing a prescription is more profitable, or it takes less time, or people don't want to do the work, they have to get better. There's lots of reasons. But if you really want to be healthy and be well, you cannot drug yourself healthy. It's just not going to work, because everything's got an effect and a side effect. You got to address diet, lifestyle issues, and root cause issues, whether environmental, emotional, psychological, whatever those things are. You got to reduce or remove those as much as possible, restore normal cellular physiology. And not only can you then restore normal physiology of thyroid physiology within the cell, what we see, and Donna, you may see the same thing if you're working with patients, is that many of our patients, not only are they, do they start to feel and function better, but we see the rest, and for many of these people, you can see their glands actually start to function and work again. And so I've had a number of patients able to come off thyroid medications over time because we addressed the root cause issues, and their thyroid gland was actually able to start to function normally again. So any parting thoughts, Donna?
No, I think the only other thing is just in agreement with you is at the end of the day, you want to slow or halt that progression. And so the more you do to identify that root cause and limit those, external factors that are contributing, the better it's going to be for you. Like you said, the medications are a support, but it's so much deeper and complex than that.
Yeah, and sometimes the easiest thing, the things that are the most important to do are the things that people don't want to do, right? Yeah. It's dietary changes, it's working on their sleep habits, their lifestyle habits. I'll finish with this. I had a patient, I'm talking to him about breathing and proper breathing, what I call respiratory fitness. And he's tired and fatigued in the morning. Every morning he's waking up. I'm like, look, put nasal strip on, do mouth taping, see how you do. Didn't really want to do it in the beginning. No, I'm not doing that. Stupid. I'm not doing that. But after committing to it for a week, he's like, I can't believe how much better I feel in the morning. I can't believe it. I've got so much more energy. And I'm like, right. Because if you're all night you were mouth breathing, that's creating stress. It's creating hypoxia. You're constantly waking yourself up, disrupting your sleep. You're raising your blood sugar, epinephrine, cortisol, all these things that are contributing to your health problems. And yes, we can try and band-aid you with medications and supplements, but the easiest, simplest thing to do was just improve his breathing, especially at night. Almost essentially free, right?
Yeah, right.
But it took probably a couple months to convince him to do it. But once he did it, it's like, I can't believe I didn't do it sooner. It's little simple things. So Donna, we appreciate you being on so much. People want to find out more about you and you and your blog. Where can they find you?
Well, I'm on Instagram and Facebook, Dr. Autoimmunegirl, and also on my website, DrAutoimmunegirl.com. You can subscribe on there. In 2020, I will be providing nutritional pharmacy services for patients that want to look at kind of that approach to balance nutrition and medicine. So social media is not always the easiest way to get the information out there. So please subscribe, and you'll be first to be aware of when those services are offered.
Awesome. Hey, thank you for coming on the podcast, Erica. Great seeing you again, and we'll chat soon. But Donna, great information, and we'll look forward to maybe getting you on in the next 6 months or so. Get you back for another update on what's going on in the world of pharmacy and this kind of blend that once you're getting a little bit more in there is with what we got planned in 2020. Other than that, we'll let you sign off. We'll all sign out of here. And for anybody who's looking for more information, you can contact Dr. Erica or myself in our offices. And if you enjoy the podcast, please go leave a nice 5-star review for us and tell your friends and family. All right. Thanks, everybody.
Awesome. Thank you so much.
Yeah.